Pseudomonas is with the kids in the unit, preterms. If they get pseudomonas now, you have to treat them systemically. All right. Chemical. Now this came into factor this big question. I don't even know if they ask this anymore in boards. With the first 24 hours, well, they may ask because erythromycin, some kids react to it. So chemical is usually within the first 24 hours following prophylaxis. We used to use silver nitrate. And we're still using it when I was a resident. Now they use it. And they may still use it in some parts of the world. I'm not even sure that they can't get erythromycin. But we used to use 1% silver nitrate, and they used to react to it. You get the discharge, right? Neisseria gonorrhea usually from the 2 to 5 days of life, abrupt onset, extreme, copious, purulent, bilateral discharge, medical emergency if not progressed. It may progress to corneal ulcerations, treat, return generation self-exposure. Of course, you want to irrigate the eye. Prophylaxis is erythromycin if applied less than 1 hour of age, increase incidence 10 to 15, then to 0.5%. So even if they were positive, right? Okay. Chlamydia. So chlamydia is 5 to 15 days. Most common cause of conjunctivitis in the first month of life. Initial watery discharge becomes purulent, often associated with pneumonia. We don't see the pneumonia at birth, so the chlamydia wasn't treated. You worry about more of the conjunctivitis maybe at birth, but what you see in the newborn is that they'll come into pediatrics later on with like a hyperinflated picture on the X-ray or chlamydia, right? Again, you treat with erythromycin. Neonatal herpes. Of course, this is the most, no history of mom. Pediatrician, he comes to the office, and in that 4 days to 3 week range, you don't want to miss this, right? Error on the side of caution, you treat. Most of our herpes that we got in ICU or the past that I've known, there was no history in the mom, asymptomatic moms. Okay, so they come when you tell the obstetrician, go examine the mom, coach the mom again. If they come to the office, call the obstetrician, you let them know who delivered you, and tell them to go and examine the mother. So that'll help you in the diagnosis. But unfortunately, the big thing is you don't want to miss it. It's difficult to diagnose sometimes. So chemical, remember chemical. The whole scenario was the baby had discharge within the first 24 hours. Usually it's chemical. Less than now because of the still there. Some babies react to the erythromycin. 24 to 40 hours bacterial, right? Okay. Again, 2 to 5 days. You worry about the Neisseria chlamydia. I told you. So fetal growth, hormonal influence, insulin is the most important, right? So growth factor in utero. So hormones for fetal growth are made by the fetus. So babies that are not controlled, moms that are not controlled with their glucose, that's what you get fetus, infant of a diabetic mother. These babies are macrosomic for the most part. You can get IUGR babies with moms that were diabetic because of what? If they have vascular disease also, that means the placenta is going to be affected also. The vessels, the arteries, the vessels supplying the placenta are going to be affected with this mother. Other hormones include thyroid hormone, growth hormone, androgens are not that are present but less important. So infants with growth hormone deficiency or hypothyroidism are born appropriate for gestational age. All right? Have nothing to do with in utero. All right? Maternal factors, of course, maternal birth rate is more influential than paternal birth rate. Age, the lower birth rate with teen pregnancies, or the lower birth rate with premature heartbeat and grand. Right? Race, variable between races, socioeconomic, of course, the lower birth rate with lower socioeconomic, right? altitude, okay, low birth rate, right? So the curve is those curves that we have are um, averages, all right, that they find. But depending on where you practice too, you may see a lower percentage, right? Poor weight gain due to inadequate maternal nutrition will lead to decreased fetal weight gain during the third trimester, not important in the first and second trimester, due to relatively large nutrient supply and low fetal nutrient demand, right? Multiple gestation, so you see the curves as you go, the more you have babies. Uh, uh, the weight really starts falling off when you have triplets, right? With twins, you don't see as much until later on in gestation, right? Um, I told you this. Glucose substrates, glucose accounts for 50% of fetal energy production. Remaining combination of amino acids, lactate and acetate. Fetal development is characterized by sequestration pattern of tissue and organ growth, differentiation and maturation. The course, like I said, maternal environment, uroplacental function, and of course genetics, right? So if mom and dad are both 5 foot, don't expect a big kid. It should be appropriate SGA well rounded, right? So low birth weight refers to any baby born less than 2,500 grams. All right, and this is just the growth rate for per gestational age. So you see here, right? So this is where we get our 30 grams, when they're born. Or we say we look for anywhere from a half an ounce, 10 ounce. So when we have a preemie who gets over the acute phase and we're up to with nutrition, we're looking for a half an ounce to an ounce a day growth, right? Right, so you can see that from 1 week to the next week, you multiply by 7, you're expecting that much amount. If you're not getting that, means something's going on, right? And what inhibits this in the NICU with these smaller kids, these 24-weekers, is if they have a lot of lung disease, they have GI issues that we can't. Again, enteral feed is the best way to gain weight. TPN works, but it's not adequate. Sometimes you can't give enough of it, and you can't give enough of non-protein calories, right? And so the non-protein calories is what's going to uh, uh, make you use the protein as building blocks. If you don't have enough carbohydrates and fats, right, with the protein, then you won't gain weight, all right? You gain the appropriate weight. You won't build muscle, right? Yeah. Weight gain for term, when the growth is expressed as percentage increments per day, it is greatest during the embryonic period by 85% of the birth weight, right? IUGR, SEA, although relatively related, not the synonymous, right? So sometimes it's semantics. It is a deviation from or reduction in the expected fetal growth pattern, and it's caused by multiple adverse effects. So you always think of IUGR as pathological in this sense. So you don't have to be. So SGA is a percentage, right? The fetus whose weight is lower than the standard population, typically less than 10%, right? IUGR, right? The rate of growth less than the fetus' predominant genetic potentials accounts for 4 to 8% of the fetus, right? So the problem is that you could be IUGR, but you don't have to be, SGA, right? It's just that you fail to reach your potential when you look. Right? IUGR fetuses may not necessarily be SGA. May still be within the population-based weight, but they don't look healthy. But you can be SGA, but you don't have to be IUGR. Okay, because you can get, like I said, mom is 4 foot 12, and dad is 4, and you come baby small, and in 10 percentile, less than 10 percentile, but you see subcutaneous fat and the baby's well formed, then it's it's genetic more than anything. Right? He's SGA, but he's not pathological. So think of, like I said, IUGR is pathological. Okay. This is the movie Twins, Danny DeVito and Arnold Schwarzenegger.
Yes.
It's an old movie. Yeah. So this is Danny DeVito. This is Arnold.
Tenés famosos.
Okay. And then you have your your curve. All right. So our biggest problem in the NIC with the preemies is that we get babies that are appropriate for gestational age in this range group, and they leave here. Okay. And there's a big push in neonatology in terms of trying to standardize feeding, which is comical because there's so many factors that come into play, and whether or not what's your incidence of necrotizing enterocolitis in the unit, how fast you can feed the babies, and of course the preemie, the gut is never normal. So anybody can feed a 26-weeker who has no abdominal distension and get them to gain weight, stay AGA. If they have no lung disease, if they have the tolerance in their feeds, you'll be fine. You'll be AGA. So so this whole consortium about feeding and trying to make things standardized is goes out the door the minute the kid oxygen requirements go up, his belly gets distended. You know what I mean? It becomes right away you start. If you look at the curve, you see these babies, the ones that were chronic. We started here, we're over here on discharge. So it's a big thing because what are we doing to the brain? Okay, and that's why it's so difficult to give a mother a prognosis. In terms of a 20-something weeker, because there's so many factors that come into play, with the morbidities, all right? And they're all intertwined in terms of development. And nutrition is a big thing. So the big thing that was changed in the unit, and what they changed in there, is starting TPN or giving protein right away, right? Years ago, we used to wait. We don't wait anymore. We try to get the protein in right away because that they've done studies and they've shown that once you're behind, you pretty much don't catch up. So it's very important to get that protein in and start and get them in avoid a catabolic state, all right? But very difficult. Again, maternal factors, I said, we talked about this, but again, drugs, right? No cocaine, depending on these moms, some medications, right? If mom is hypertensive, the placenta is not going to function properly. The baby's going to be maybe small, and all these chronic diseases. So these you get with advanced maternal age, moms that were infertile, that they do IVF, and you're dealing with these babies that don't grow well, right? Uterine placental insufficiency, most common cause, right? So now you see that kid that was born with that COVID, mom was sick as hypoxic in the unit for a long time, and that kid's growth was affected, and also the brain, So again, high temperatures can affect the brain growth, right? You worry about moms, getting sick. That's why they said, no hot tub, stuff like that when they're pregnant can affect brain growth, and of course chronic hypoxia. So mom was hypoxic for a while in the ICU. We were waiting on standby to deliver. The question is that, looking back at it, was it a good thing to leave the baby in or deliver it? That's here or there, So they get a whole bunch of these kids that were delivered like this. There was a bunch of moms that were pregnant that were sick from the COVID, that we were waiting on, that other hospitals, emergency C-sections, mothers were getting intubated. Some moms passed and they did emergency C-sections. So we heard from different places. So fetal anomalies, particularly cardiac and renal infections, multiple gestation, look for babies with IUGR. Okay, so Again, I talked about um, the head circumference usually symmetrical, proportional, right? SGA, way symmetrical, right? So you're looking at this was later on. This may be early on in gestation, but they're symmetrical, the insult, all right? If again, it could be genetics, so they would be symmetrical. The baby's head percentage of the head and the body would be later on. If the head there's head sparing, then you know the more likely there was placental insufficiency, right? You look at the ponderal index, the low risk of perinatal depression. So a baby who is SGA but is well nourished, right, will tolerate labor well. A baby who is asymmetric, right, has a good head circumference, but the rest of the body is wasted, is not going to tolerate labor. All right. So years ago, those are the kids that we see a lot more with the 60s. When they tell you that there's an IUGR baby in their mom's in labor, expect the baby to be compromised. That they're going to do a section, or they may call you stat because the tracing went bad. All right. Blood flow to the internal carotid is abnormal. Increased thus the brain is bad. Again, this they call what the diving seal reflex. Right. When a seal dives underneath the water, right? They're mammals. They take a breath. They fish underneath the water, so they divert their blood to the brain, heart, and adrenals. So they give up everything else: their liver, their intestines. Okay, blood flow. Again, I said we said internal carotids, normal, low risk of low glycogen, low fat stores, so increased hypoglycemia. That's why it's in the protocol if they're SGA, right? And especially IUGR, asymmetrical, you more tend to be hypoglycemic in newborn nursery. That's why you watch them for 24 hours. Again, early on, you worry about more chromosomal, right? Anomalies, torch, right? With environmental preeclampsia, hypertension, severe diabetes. Anything else? I told you about the hyperglycemia. Why? Perineal, I told you about that. Hypocalcemia, and again, polycythemia, chronic hypoxia in utero, right? Increased erythropoietin, right? Reduction. All IUGR babies have a hematocrit greater than 60%, so they're going to secrete, they're going to produce more, so they're more apt to be polycythemia. You got to watch out for that. All right, let's just go past this. Just can't read. Again, insulin cannot cross the. So if mom gets insulin, it's not crossing. That's not. Or mom insulin doesn't cross, right? Growth enhancement hormone and fetal origin. I told you already. It promotes fetal adipose glycogen stores, right? We had one years ago. You look it up, leprechaun. Looks like a baby look like a leprechaun. Very IUGR in growth, and impaired insulin secretion. Right, baby ended up expiring, severe IUGR. Low birth rate in the fetus has been related to subsequent risk in adult, hypertension, a large percentage. Non-insulin dependent diabetics, short fat babies, strokes, obesity. So some of the things that they see in utero babies, they can relate to later on in life. Neonatal mortality is directly related to less than 37 weeks term, but reduced weight. Certain otherwise normal mothers are prone to repeated deliveries of infants who are SGA. The recurrence rate may be about 25 to 50%. So if mom was SGA, more likely to let the baby. See, mothers who were born SGA, raising possibly intergenerational transmission of physical regular fetal growth. So if you were SGA, you don't have to have a baby with SGA. It's not good. Again, just with the placenta quick, contains numerous branches of villi that suspended into the intervillous space, branches of umbilical artery entering the intervillous and end in the capillary plexus, right? So we're not gonna go through all this. You can see the mom's made up of, it's almost like the lungs, right? Multiple lobes, all right, that supply blood flow to the baby, supply nutrients to the baby, all right? We talked about this. Talked about this maternal practice. Chromosomal diseases. Go past this, right? Okay, the cigarette. Cigarette smoking, comes up and gone. It's been studied so long. Mainly with the weight gain, you worry about the other things in terms of the vascular component of things, even with the cocaine, right? We worry about this is the most important thing. So the baby's more predisposed to vascular issues later on. NECs, a higher incidence with cocaine moms, right? They can get a brush or placenta. That's why anybody that a bus, we tell them to do urine tox, right? This is the ponderosa index, right? It's the index that they use, right? Assessment of growth, retardation, utero, right? And this was with the hypothesis about maternal hyperglycemia, fetal hypoglycemia, cause, right? And they don't know why, but these kids, when they get the term, so that's why most true infant diabetic mothers who are insulin dependent, the baby will tend to deliver around 36 weeks, 37 weeks. They don't go past. Because if they let them go, this is what happens. This is what they fear the most. You get these big kids that is 8 pounds, 9 pounds, and boom, just spontaneously abort. So that's their biggest fear. They don't know why. Right? This is for infant diabetics, again, hypoglycemia, right? Hypocalcemia, maternal loss, birth asphyxia, big babies get entrapped. Failure to mount an appropriate parathyroid response, persistent levels, high levels of calcitonin, hypomagnesemia, maternal loss, decreased ionized total calcium, increased phosphorus, decreased parathyroid. All right. Again, polycythemia. If mom has big baby vascular disease, you're going to get increased. The bigger the baby, the more blood supply. Also, hyperbilirubinemia. Like I said, most of them are born 36 weeks prematurity or polycythemia. You get macrosomia with organomegaly and perinatal asphyxia because of that. The way the placenta flow, if there's vascular disease also. And big babies, they're trapped. We don't see the like we used to see all these because we don't generally moms are well controlled. So this is for test purposes. I can't see the last. I mean, the last quarter regression syndrome I saw was back in 1990 in fellowship. 90. Well, I got fellowship from 94 to 97. So that's when I saw the last quarter regression syndrome, and that mom was not freaking no thing going for prenatal care, nothing, and that kid came out. It was classic quarter regression. We do see small the left colon, microcolon, right? Diabetic. We just had one. That baby looked like mom was diabetic. The cardiac diseases, the most thing we see is the hypertrophy, which resolves in 6 months. All right. The rest of them, I mean, myocele and encephaly, the mom really has to be a high control, and we hardly see that now. Okay. The blastosis, we had one. Baby was seized downstairs in newborn nursery at 24 to 48 hours. Classic. Came up, severe hypoglycemia. We couldn't regulate went to the shop and they finally did a subpectin. remove some of the pancreas. Okay. Becker-Beaman syndrome, macroglossia. Remember Becker-Beaman, well, big tongue, the foul cell, right? Help. These are just things that they'll tell you on the exam that the mother has all this, that something's going on with the mother, so the baby's going to end up being delivered. Baby may be compromised, right? Because the mother's compromised. Right? Preeclampsia and help. Right? It's good to give a mother help, preeclampsia. Ask her what would be the baby's outcome. IAGR, of course, with the preeclampsia, perinatal asphyxia, thrombocytopenia. May ask the mode of delivery. Remember, the mom, baby's less than 50 down. The platelets are low, right? Depending on the fetal lung maturity. If the baby's IUGR, it helps with the lung maturity, right? Increased mortality 5 to 20% compared to AGA. You know, it's probably decreased because we don't see them going further with them. Once they recognize IUGR, they tend to deliver early and do so. Years ago, when during residency here, when I was a resident, this was the standard. No fluid, baby small. You go down there, thick meconium, the baby comes out asphyxiated. It was kind of crying, you know. But now, most of the time, they'll pick it up. Increase, of course, IUGR, increased ICU admissions. Of course, with like I told you before, can affect the babies, adults. If they have some hypertension, glucose adults later on in life. LGA refers to an infant whose birth rate is above the given percentile, greater than 90. So it's not one weight, right? It depends on the gestational age. So if your gestational age is 36 weeks, you're about 90% down to the LGA, right, for that weight. Okay? So when you do your telling them when to monitor, I make that little chart there for each weight, give or take as a cheat sheet, that if you're this weight and you're this age, gestational age, then you're LGA, right? You should watch your sugars. Again, macrosomia greater than 4 kgs. Large for gestational age, again, 20%. Again, you worry about that with reading, right? Eye drops with towels, so those are going to be a demoness. This is just again when you're in the delivery room. I could print out a copy for you, but just in general, you look at certain things, right, and the ballot score just to determine the gestational age. All right, there's more to it. I'll print it out. I can give it to you. So prematurity, right? In the U.S., 12.5 of all premature less than 37 weeks. Low birth rate less than 2,500 grams. Very low birth weight is less than 1,500 grams, and extremely low birth less than. Then you get the micropremies. While premature survival has increased, CP has remained constant. And that's the problem. We've reached a point that we've improved. The big thing in neonatology is we improve survival. When I was resident here early on in fellowship, saving 27-week, 28-week was still a little difficult. Now it's like you don't even worry about that. I would say our survival rate from 25 weeks to and above is extremely high. Anything below 25 weeks, then the mortality, right? 23 weeks is about 50% still, right? Now, a lot of places are saving 22 weeks, right? Well, again, fibronectin, right? This was with that baby Kindred, came in. So her fibronectin was elevated, so they kept her because chances are she was going to deliver. So there's no sense in sending her home. So they'll do that, and they'll use that as a delivery is imminent. So there's no point to sending the mom home because she's going to deliver at home. Right? Of course, the biggest thing that they've done in OB is perinatal corticosteroids, right? Effective within 12 to 24 hours. Initial dose, maximum effect in 48 hours. That's why they try to wait, right? It lasts about 7 days, and they would give a rescue dose. Before, when they first came out, they would give multiple doses even after that. And these kids, it would affect lung maturity to the negative and also brain growth. So you don't want to give too many doses, all right? Decreased incidence of severity of IVH, decreased incidence of NAC, right? And the question is, does it have the steroid does it have a direct effect, or the fact that it's giving us a less sicker baby, and then means if you have a less sicker baby, you tend not to do as much, and maybe that decreases. A less sicker baby, perfusion is better, you may have less, right? Again, this is betamethasone is definitely better than Dexa. I don't know why we were using for longest time Dexa, but they went to betamethasone. All right. Post-states, 10% of all pregnancies. Again, it's very rare to see 42 week now. Usually unknown etiology, right? Fetus will have decreased growth. The placenta ages, right? Gets calcified, so it's more apt to have more issues if you wait to deliver. That's why the moms first pregnancy they'll wait a little longer, but if she's not, they'll come bring her in to do so, right? You see the peeling skin, right? You see the meconium stain, right? So 15% of the babies will pass meconium at term, right? You usually don't see meconium before 36 weeks. If you see meconium before 36 weeks, you're in big trouble. Either that or baby's infected or baby's really stressed. So, but you see is that meconium, the nails are stained, right? Right? So he was swimming in this meconium for a while. Okay? You see the skin, right? You can see start seeing some wasting, right? So you talk about the fluid and electrolytes, total body water, intracellular fluid and extracellular fluid, right? And you see here at birth, right? They have the amount of total body water is increased, higher level percentage of the baby's weight, right? Then if you see that initially they'll lose a lot of fluid, right? And decrease the body weight initially. They all go through that diuretic phase. Total body water decreases with gestational areas remains the highest. Extracellular fluid decreases, intracellular fluid increases. They cross about 3 months of age, right? So just a rough estimate in terms of what, the first day of life, right? Again, it has to, this is changed because of, with these lower workday babies, we put them in the giraffes now with humidity. Hopefully, you have to give less fluid. That sometimes it doesn't, but this varies. We use sodium, all right? A lot of the places will use their blood pressure, this and that. They weigh the kids every day, but we use sodium as a marker in terms of fluid, right? And of course, visually. After about once we get past the acute phase, usually we keep them around this range, all right? And as they get older, then we try to get up to that. But around 8 days of age, or a little less, around there, we try to get them to restrict them. Why? Because most of these little ones will have some sort of lung disease, capillary leak. So the more fluid you give them, the worse things get. They leak out, the oxygen requirements go up. We worry about the ductus arteriosus. So we tend to keep them on the dry side, all right? For full term, when you get the birth rate, you can see the accessible water loss is going to be less, right? And you start off with less fluid, right? You can see that the accessible water loss on a 20-something week. Look how much, compared to 42, right? Maintenance sodium and chloride should not be provided in the first 1 to 2 days of life with a preemie of life because of the relative volume expanded state of the newborn. This is particularly important in very low birth weight babies. So with full-term babies, their kidney function is almost, as the days go along, it increases the adult levels pretty rapidly, and so they can handle their and adjust. So the low itis, even in the unit, you feed them. Usually you don't have to supplement them. So any baby that's full term that starts getting hypernatremic on you, right? You correct it initially, right? Then you should stop it and lower it down to the minimum, the standards, and challenge the baby to see if there's something underlying. So for the most part, some will go back to normal, right? So years ago with the obstetricians, what they were doing, they were giving mothers free water, just dextrose, and these kids would come back out mom would be hyponatremic, the baby would be hyponatremic, right? Because the placenta has diffusion. So if you're making the mother hyponatremic, it just goes across the fluid, and the baby becomes hyponatremic. So this is particularly important. And I said with the low birth rate babies, we got a better handle on it. That was one thing I differed from my mentor. We used to keep them a little bit too dry in the beginning, so we dealt with a lot of these kids would get hypernatremic, hyperglycemic, and you get hyperosmolar syndrome with these kids. So, and the hypernatremia can cause the babies to have intraventricular bleed, so you got to be very careful. So we right now what we do is give them a little bit more, see how the sodium is, and then go from there. Because once you fall behind, it's very hard to catch up with these little ones, especially with the fluid. Potassium is not provided in parental fluid until urine flow is established, right? Postnatal days, about 3 to 7 maintenance sodium, potassium chloride requirements are approximately 1 to 2. Beyond the first week of life, 2 to 3 MEQs per day or more sodium chloride is required to maintain positive electrolyte balance. Glucose. The fetus receives continuous flow of glucose to facilitate diffusion. The question, the glucose level at which you would intervene. Now the problem with this is the old question. I don't even know on the boards. If you ask the endocrinologist, it's one value. The AAP guidelines are much less. So it's still no one knows. I'm curious to find out in another year or so, 2 years, if somebody going to look back at the AAP guidelines and see if there was more complications, more issues, because I think their levels that they picked were extremely low. And again, it's for the ideal situation, you have a lot of staff. No one has a lot of staff. So, after birth, plasma glucose concentration falls in the infant, reaches the lowest value 30 to 90 minutes after birth. So, thereafter, full-term healthy neonate plasma glucose concentration rates between steady from anywhere from 40 to 80. A full-term baby infants can tolerate fasting without significant change in blood glucose. Right? So again, this has been looked at so many times. I mean, I'm happy that they came out with guidelines, but I didn't use them. I adjusted them for where I work, and you know what goes on. If you've been here for 3 years, you see what goes on downstairs. Hypoglycemia levels less than 40. Blood sampling needs to be processed quickly. So the problem is, even AAP, the guidelines, if you look at the AAP guidelines, It's central sticks. You know, who the hell is going to draw central blood? Send it downstairs. By the time the lamb does it, either it's going to be low because it's been sitting there. So it's not ideal and stupid, and no one has that manpower to go and draw a central. You know what I mean? So, you know, it's the insurance companies love to use it. You know why? Because they deny days. They come. This wasn't hypoglycemia. Like, who in their right mind? So you want me to let the baby become hypoglycemic and seize so that you pay me? You know what I mean? The way I practice in the unit is once they're hypoglycemic in newborn nursery, you already documented, do not make them hypoglycemic, let them get hypoglycemic in the NICU. Why? Because medically, legally, right? And it's not, I'm not practicing to protect the lawsuit, but it doesn't make sense that you're treating somebody for something and letting them get hypoglycemic. So there's no point. So give them enough, which is a guess in the beginning, but give them enough so they don't get hypoglycemic. Sometimes it doesn't work, they still hypoglycemic and we keep constantly going up. But you don't want them to become hypoglycemic once you start to treat them. There's literature out there that, these subtle tremors, these kids that are riding in the 30s, and then later on have, if you look at the lesions of true hypoglycemic persons, the lesions in the brain are similar to hypoxic lesions, all right? So it's not something that, and if you look at VOPI, years ago, VOPI had a chart of the most common newborn causes for newborn seizures was hypoglycemia and hypocalcemia. That's why we have safeguards against that. The kids' tremors, we do calcium release, right? We go with the birth rate or history, and we have alarms that ring off to do test the baby's sugar, all right? Etiology of hypoglycemia, prematurity, secondary inadequate glycogen stores, hyperinsulinemia, ID and baby SGA, twins, depression. I was my predecessor and most we push when I'm baby downstairs and I'm resuscitating the baby, I push the extra. Some patients don't do it, but they look at the sugar afterwards. I do it before, so that when they come to deliver, come up to the ICU, the sugar's normal. At least that's take care of. Again, diabetic mothers, hypoglycemia, fetal hypoglycemia, fetal insulinemia, hyperinsulinemia, right? Fetal substrate uptake, right? So you get the decrease, it affects the lung. That's why a 37-weeker, 36-weeker, that's an IDM, more apt to have surfactant deficiency, right? They're going to have RDS, all right? You get oxygen increased uptake, right? Hypoxemia, right? Stillborn, which again, they don't know the true etiology. Increased erythropoietin and polycythemia, that's one reason, right? And again, microsomal. And what's this? Backward 3, right? So it's on the top. BWS. But that's right? Big baby, that's a ophalocyte, right?
Yeah.
The difference between ophalocyte and gastroschisis, ophalocyte has a cover, right? And gastroschisis has no cover, all right? Right? The ear, big tongue, both folds in the ears, right? Hypoglycemic etiology, hormonal abnormality secondary to panhypertension, growth hormone. That's why we draw. That's why when they're hypoglycemic, the low 40s and they're persistent, we draw the cortisol, right? Growth hormone, right? With these kids, right? And insulin levels, right? Hereditary anomalies, glycemia, of course, like those, when your treatment is not working, you look for the zebras, right? You start looking. Clinical symptoms, of course, again, it varies. I don't know, cry, irritability, apnea, cyanotic spells, jitteriness, tremors, feeding difficulties, lethargy, grunting, tachypnea, right, seizures, which you don't want to see, hypothermia, we call this refractory hypoglycemia if the glucose infusion rate is greater than 12. So the normal glucose infusion rate is anywhere from 6 to 8. That means the amount of glucose given the baby gets in utero is around 6 to 8. So we mimic it when the baby comes out and the baby comes to the ICU, and we're not feeding the baby for other issues. We give them around 80 cc's per kg of D10W, which gives you a GR of about 5.6. So you're on the lower level of normal, right? And the babies will tell you where they need it. You have to go up. But when you get above 12, you're in trouble because you can't deliver it peripherally, all right? You only can go with the max you can go. Peripheral IV is D12.5. Becomes an issue, you have to put a central line in and give them more sugar, right? And then you should look for the etiology at that point. Polycythemia. You are called to delivery of twins via C-section. The obstetrician informs you that it's monozygotic twins. As you arrive in the nursery, you note that one of the infants is plethoric, tachypnic, hypoglycemic, and hypocalcemic. The most likely diagnosis is
Twin to twin.
What happens usually is you'll lose this kid, the plethoric one, right? He'll clot off and die on you. Yes. You know. The other one will be distressed with what's up? All right. The other one you get is the smaller one. You know, so most of the times we get and they suspect it, we always get the bigger one is the more the issue. You know, one you're doing a exchange transfusion, the other one you're transfusing. You know, hemoglobin more than 20 grams per deciliter or hematocrit greater than 65. There's a lot of controversy what to do. Capillary values need to be repeated, of course, because if you don't warm the heel and get good flow, capillary value is going to be higher, right? Newborns hematocrit concentration peaks around 2 hours and then declines 6 to 24 hours. Venous hematocrits greater than 65 hemoglobin 22 affects 1.5 to 4% of all newborns in the first week of life. Again, twin maternal fetal transfusion, delayed core camp. Now, it's common sense, you know, obstetrician. If you have a mother who's a diabetic, you shouldn't be pregnant with delayed core clamp. You're asking for trouble.
They will
You know, and then the AP is no better because they don't come out with. No one came out with the, how to do things and what to do. Now these kids delay cord clamp, and meanwhile they hold the baby up above the mother. It's supposed to hold maybe level, if anything, or below, right? Below, you'll get more flow if you're worried about holding the baby above the mother's heart. The flow is going to go the other way. Caused by increased production of protein, secondary causes by transfer of obviously the fetus. A high hematocrit levels, blood viscosity increases, posing a potential risk of newborn. Possible symptoms of deficiency, of course, I told you, post-mature toxemia, pregnancy, placenta previa, adrenal hyperplasia, congenital neonatal thyrotoxicosis, maternal diabetes, others, trisomies, Becker-Friedman, polycythemic, primary cause fetal growth restriction, maternal insulin diabetic, neonatal. Told you that. Again, look for signs. The plethoric, the lethargic, the tachypnic, right? You see the hypoglycemic, then you should, if their usual hematocrit values over 70, then the question is, should you exchange? You know, take blood out, put saline in, right? That's the big controversy.
You don't
if
like
you
a
have
partial, right? A
what?
partial. You just take out the blood and put the saline.
I think we did it once. It was fair.
Yeah.
One of the
So it depends. It's just symptomatic. The problem is the term is symptomatic. Some of the old literature says that if you do it, there's a decreased incidence of the CNS side effects of hypocytemia, but the GI symptoms persist. Why? Because GI is a lot of people. If you do it for the central line, then you can affect GI flow. That's the word. So again, this was past required expansion of newborn. They expanded it. There's, the newborn screening is, if you look at it, it's tremendous. It's been a big asset to reduce morbidity and mortality. But the thing is, the results are coming quicker now. Depending on if the specimen gets there. So that's one good thing that they've been doing. All right, as to acceptable between 24 hours to 7 days after birth. Best time 48 to 72 hours. Before age of 24 hours, test needs to be repeated. Right? Sometimes you're not feeding enough. So there's guidelines for them to repeat. How they collect it. Premature babies less than 27 weeks collected, specimen 5 to 7 days. High risk of false positive, TPN. You try to get it before the TPN initially. They're not feeding. So in NICU, we constantly repeat it. This transfusion disorders will be masked. Early discharge is a problem. Positive screens only need further testing necessary, right? So they always send you the test results, and they'll tell you whether they want a central specimen or they just want a repeat test. All right, and this is just some of the things that we can pick up. All right. Okay, so we need mean change, right? So different disorders. The list is usually always changes. Of course, HIV. All right. This talks about PKU. Some recessive, blonde, blue-eyed, early vomiting, irritability, musty odor, late microcephaly, mental retardation. I haven't had one. I don't even know. I can't remember when the last one we had. Screen affects protein intake, tyrosine. You don't know if you're missing downstairs. You know what I mean? With the pickup in the office, right? So phenylalanine hydroxylate deficiency, right? And this is okay. So a pregnant woman has PKU. The baby will immediately have PKU, phenylalanine, or there's no issue. So the mother has it, right?
Okay.
It's like recessive, right? So it's not.
No issues.
Not fully being.
Right, moms with PKU becomes and causes miscarriage, SCA, microcephaly, cardiac anomalies, and mental retardations. And that I understand that babies does not have PKU comes right there. The nurse informs that she has do CBC on the baby, suspected sepsis. Since I already drew the blood for PKU, the screening comes back positive for hypothyroid. Most likely is what?
Too early versus too late.
That's the most likely.
Timing of draw.
Timing of draw, C.
Right. So, again, I told you with the thyroid, majority of thyroid is low, then determined T4. I don't think they're reporting, I forgot what they said, they're not reporting the TSH anymore, so I forgot. They're just reporting the TSH, not the T4 anymore. Ideal to sample between 48 to 72 hours. Avoid samples before 24 hours. Right? So that's the most common one we get back that you have to repeat. It's important not to miss it, of course, like always. Usually when we get an abnormal back, I tell them to just send it central. Because by the time you send another specimen, get back, you waste another 2 weeks. So as a pediatrician in your office, if you get it back right away, just send it central sample. You'll have the result in 24, 48 hours. If you send it to the state again, it may take a little, it's a mail, this and that, the inappropriate the way they collect the specimen. So always do central. Don't, this is something that you can treat. So don't fool around with this. All right.
We can take the blood and send it manually, like the TSH, just as a lab.
Yeah.
Yeah.
Yeah. But the state wants you to repeat it. You gotta send it to them because they'll call you and they'll bother you. If abnormal screening, repeat T4 TSH. Confirm if abnormal, consider measuring free TBG, free T4 TBG, and all that. You do the workup. Obvious congenital hypothyroidism occurred in 1 in 140 subjects with Down syndrome. Again, Down syndrome incidence has been increased. You know what I mean? Why? Because I think a lot of people do the chromosomal studies and if they're the risk for that, and then they determine to terminate more likely. You can see we don't get that often. We don't get see Down syndrome as often as we saw before.
One.
Right.
Yeah.
Right. So 90% should be detected in the newborn period. So this is a big push a number of years ago. That's why all the hospitals have this set up for screening, because if you have to detect their loss, right? And you do ABRs or evoked respiratory response, right? Two screening methods. Well, they may ask you, but this is just the time. They only gave me 2 sessions, you know that. Usually I had the whole month. I don't know if I could finish.
Dr. Barone, if we can give more, like if you want to do more.
I'm just telling you that usually 4 sessions I never finished all the slides. You know, I don't know. So the major thing is you want intervention before 3 months, right? So they may give you a scenario, blah, blah, blah. I think, you know, I don't know how specific they are with the numbers in terms of the decibels and stuff like that. They may give it in the history of the question, but you have to intervene and definitely diagnose it, try, you know, determine ideal mode of assisted amplification. It's very difficult. I talked to parents. One of the nurses had one of the daughter had to keep this thing on them. You know what I mean? To improve the hearing. That's the only thing. It's not ideal. Even though when they set them up for hearing. Question: what percentage of infants were referred for formal hearing screening after initial screening? 2 to 5%. What percentage of infants that failed the initial hearing screen have actually hearing? About 20%. That's a big number, so it's important to capture, you know, and not to let it go. You will get sued. On the average, 2 to 7% of infants will be referred. Of the 80% rescreen, 20% will have true hearing aid. The critical window, right? Neuroplasticity during the first 3 years of life, the early intervention, best chance of achieving appropriate language and communication skills, right? So it's important. Court care. We don't do ice alcohol.
The hearing, I know that we are, CMD is one of the possible causes.
Well, now that was the new guideline that if they fail, you gotta send the CMB. Yeah. Right. Yeah.
All that storage can cause too.
Right. Right. This is why, you know, we used to send it mainly for the IUGR babies or the preemie babies. Why? Because we would transfuse them and all that, and you want to make sure that you document the negative, and then, God forbid, the blood supply, you know, we get it. But you know, IUGR is one of the causes. The yield is very low. I can't remember the first positive, you know, but it's there. Has been proven to be effective. So you don't do alcohol. We used to do the alcohol. They used to tell the mothers to, to dry it out with alcohol and stuff like that. We used to use methylene glue on the cord to dry it out quick. Don't do that anymore. So just allow for natural drying. But again, if it's all wet, you gotta tell the mother to clean it. All right. So this is arthritis. Right? Watch. I can't start another one. There's this one had I know. I did what, 200 or something? There's 360 something like
Pure 191.
We are at 9.
No, I didn't. I finished all those. I did 200 something. I skipped over. Right? That was finished.
Yeah.
What?
There were 300 something.
We saw 192.
You said what?
So in the next section, we need like 300.
192.
We want to see all of them.
Like
I
in the
was, only,
middle.
I was only 192?
Yeah.
Oh, Jesus Christ.
Yeah.
Oh, I know why. I know what happened. I made a. Oh, I see.
Yeah, we can see that.
You kind of like made a break.
A break.
slide.
I don't know. What the hell did I do? 192?
Yeah.
The arthritis issue.
That one, yeah.
Yeah.
Oh, shoot.
Yeah.
Okay, it's good. I thought it was in the other thing. That's why when I was looking at it last night, I said, what the hell is IVH? It's got subdural full term greater than subdural, we do get babies. Trauma, tearing of the veins, right? So this is something that you may have to call neurosurgery. Right? There's a subdural, okay? There'll be doing instrumentation, of course. There was a famous reporter in Long Island. Her husband was a PNT in the hospital when I was a fellow, and she's a reporter for a news station. The kid in newborn nursery, his head going like this, increasing in size, and the kid starts to seize. I'm like, oh, shit. And transfused him because he became anemic. Did the CAT scan. There's a super tentorial bleed. There was nothing to do for the neurosurgeon, but this was news reported in. This is North Shore. Neurosurgeon wouldn't come in. The neurologist wouldn't come in, and my attendant wouldn't come into. I'm not my fellow, and I'm talking to these parents. I saw her, and I said, I always wanted to know. I wanted to know, so I sent her a message. I saw her on Instagram, and I said, I was there for 20-something years, so I can't get sued. No. I never heard anything about the case or anything. And I asked her how the son was. And he's fine. He went to college. He's in there. I'll show you the text. But it was nice to hear. But that kid sees I was transfusing him. I was sweating. So hemorrhages, posterior fossa, protectorial, severe acute lateral eye deviation of nuchal pupils, nuchal rigidity, seizures, dilated pupils, side of the hematoma, paralysis of these kids. Slideshow. Shit. Damn it. I should have been. Sorry about that. Alright, so you see subdural. Again, so we never did CAT scan. We got burnt one time, but when they seize like that, you have to do a CAT scan. You know what I mean? You have to, CAT scan is quick. MRI is good, but for posterior fossa, ultrasound's not good. And of course, you want to avoid the LP. But you want to do the CAT scan. Subdural management, emergency evacuation. And this is one kid we had that had to go to the OR because he said the kid had a lot of issues later on. Really poor after posterior fossa is severe. Less severe, treated early, up to 90% of normal outcomes. 10 to 50% have hydrocephalus, which is serious sequelae. All right. Convexity bleeds have better outcome. Subarachnoid, the most common. So these kids, if you did a CAT scan on kids downstairs that had tremors, you might find subarachnoid, right? Little subarachnoid. These kids are really irritable, right? The most common, of course, is a preterm term, often asymptomatic. May present early as refractory seizures second day of life, right? Usually good prognosis. Sometimes they don't even seize, but if you see someone with a lot of caput and went through a thing, I was going to do a study and try to develop a score, but then we had a C-section rate so damn high. But do a pain score, but a pain score in terms of when you would do a CAT scan. So in terms of how severe the head molding was, how bruised, you know what I mean? If there was any instrumentation, the irritability of the baby. You see some of these kids, their heads feel so heavy. You lift them up, they cry. Definitely something went on, you know? So to see if you would pick up, I don't think the obstetrician would enjoy it, but
Is the vacuum?
multiple times. So the door has that, this is just anatomical, right? I only got 6 minutes. Dr. McMahon wants to see me. Cerebellar hemorrhages, preterm grading, full term uncommon, can be serious, may have symptoms of brain compression, respiratory irregularities, lateral eye deviation, testimonial and OCT, long-term developmental issues, right? So I'll stop here with we'll talk about germinal metrics next time and go from there. I didn't know you were serious. Yeah, so whenever you